Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. It's our great privilege and pleasure to welcome Dr. Joe Pizzimenti to talk about the eye in sleep apnea. Now, I didn't pull up Joe's bio to read to you. I've known Joe probably for close to 30 years at this point. We worked together very, very closely at Nova Southeastern University for some 21 years. He is like Greg, he is like family to me. Dr. Joe Pizzimenti is a faculty member and full professor at the University of the Incarnate Word, Rosenberg School of Optometry, where he teaches a course in posterior segment disease, as well as working in the residency program. Now, prior to that, he was a professor of optometry for 21 years at Nova Southeastern University's College of Optometry, and we worked together very, very closely for many years, developed many programs. He was really one of the best educators that I have ever come across, one of the kindest, best people. And you know, Joe, when I was driving home, I was listening to Sirius Radio, Bruce Springsteen's E Street channel. So I thought I would, I'm going to channel Bruce Springsteen and introduce you in the E Street way. So we want to have a big OEC welcome to the mountain shaking, earth quaking, intern faking, heart quaking, love making, and Viagra taking Dr. Joe Pizzimenti. Joe, take it away.
My goodness, what an intro. What was that last one? Oh my goodness. So yeah, it has been close to 30 years, if you could believe that. And you know, I did sit next to Clarence Clemens once on a flight. So the Bruce connection is there. Well, great to be with you guys, and
John,
wonderful to be with.
Was that before or after you were on Rocky?
That was after the Rocky film. Okay. Joe, that was after the Rocky film. Oh, now we get the test question. That looks good. But thank you again, guys, for having me. It's good to be with you. Good to be with your audience at Optometric Education Consultants, and working again with my good friends Joe, Greg, and Vanessa. Do I know someone with sleep apnea? Yes, I do. Every time I look in the mirror, I see him. In fact. And
I got it rolling here, Joe. So we'll see what happens, and
yeah.
I'll just share the results and go ahead and get cranking.
Yeah, I'm waiting on my new CPAP unit. It should be ready any day, so I'm pretty psyched about it. All right, so this is the eye in sleep apnea. That is my university email address in case we don't get to your question this evening. I don't have much at all in the way of financial relationships to declare for this particular talk. And I do want to encourage everyone to go ahead and use the chat box, the chat widget. And every 20 or 25 slides, I have a built-in break when you'll see a slide that looks like this. And I'm hoping that we could take a break and answer some questions. But really, any time is a good time to type in a question. And so our goal over the next 100 minutes or so is to provide clinically relevant information about sleep apnea and its ophthalmic implications. As you could see in our diagram here, the upper airway collapses, blocking the airway. So anytime we're dealing with a public health issue, and that is what sleep apnea has become, it's a legitimate public health issue, I always like for us to describe the problem before we go ahead and try to attack it. And so, the sleep apnea syndrome is a disease. It is characterized by recurrent, complete, or partial obstructions of the upper airway during sleep. Now, the majority of people living with sleep apnea have the obstruction either at the nasopharynx or the oropharynx. And as you can imagine, the obesity epidemic is just one of the things that is driving an increase in the sleep apnea syndrome prevalence among really all age groups. So we're going to use this case as our basis for discussion, as a framework for our sleep apnea talk. This was a 32-year-old white male, an accountant, nice guy, family guy, 5'8", around 265 pounds. His chief complaint, "Doc, I see red out of my right eye," and it's not difficult to see why, with the neovascularization of the disc and the pre-retinal heme and so forth. All right. Now, the left eye also has what appear to be some fibrovascular bands in the mid-periphery and a fair amount of macular edema. Anytime we see exudate in this manner, it usually represents a bridge between flat retina and swollen retina. And so our patient was diagnosed with type 2 diabetes 3 years prior, and he probably had been living with it for longer than that. Same for his obstructive sleep apnea that was just recently diagnosed, although based on his symptoms, he has probably been living with sleep apnea for a few years. And you'll hear me use the terms obstructive sleep apnea and sleep apnea syndrome, interchangeably for the purpose of this course. Really, we're talking about the same thing here. So let's define sleep apnea. An apnea is defined as a complete cessation of breathing for more than 10 seconds during sleep. An obstructive sleep apnea is characterized by repeated episodes of apnea or periods of shallow breathing throughout the night. Epidemiology-wise, obstructive sleep apnea is most common in overweight or obese men, and it occurs in about 22 to 24% of men and 9 to 17% of women, depending on which literature you read. African Americans have a 2.5 times higher risk of developing sleep apnea than do Caucasians. Obstructive sleep apnea occurs in 34% of the linemen that play in the National Football League. So the offensive linemen, the defensive linemen, nowadays, they're well over 300 pounds, 325 pounds. I mean, when we were younger guys, the linemen, they were maybe 250, 240, but now they're just supersized. And unfortunately, these young men develop sleep apnea, and folks have died as a result of complications from sleep apnea. Probably the most famous of the NFL linemen that passed from the condition was Hall of Fame defensive tackle Reggie White. And in fact, his family has set up the Reggie White Foundation for Sleep Disorders Research and Education. And so Reggie White, one of the first NFL linemen to succumb to complications from sleep apnea. And so this is a potentially deadly condition, unfortunately. And there are a few different types of sleep apnea. First, there's the central sleep apnea type, which is caused by the loss of ventilatory effort, and this is moderated or controlled by the central nervous system, where the brain does not properly tell the body when to breathe. Now, less than 1% of all patients with sleep apnea have the central sleep apnea alone. Obstructive sleep apnea is by far the most common type. It is caused by an upper airway obstruction or collapse, usually in relation to a wide neck girth. And roughly 85% of all patients with sleep apnea have the obstructive form alone. 15%, therefore, have a mixture of the central and the obstructive form of sleep apnea. So I learned that even when I was, 25 pounds thinner, I had the central form of sleep apnea. But then with a bit of weight gain, I ended up developing the obstructive form too, so I'm in this mixed 15%. So the mechanisms underlying the different types of sleep apnea, there's a lot of overlap among the three forms. And so in obstructive sleep apnea, there's an average of at least 10 apneic and hypopneic episodes per sleep hour. And this will then lead to excessive daytime drowsiness. This is something that I began to experience when I was first diagnosed some 20 plus years ago. So excessive daytime drowsiness because of the marked fragmentation of the sleep. You'll get a couple of hours, you'll stir a little bit, you'll get a couple of more hours, but it will not be quality sleep. Now, there are other causes of obstructive sleep apnea. For instance, physical obstruction of the airway can result from anatomical factors, whether it's enlarged tonsils, an enlarged uvula, an abnormally large tongue size, or an abnormal craniofacial morphology, which we see in conditions such as Marfan syndrome. So why should we care? Why should we as optometrists care about sleep apnea? Well, because it's an optometric disease. That's why we should care. And reported ophthalmic findings in patients with sleep apnea syndrome, the list is fairly long, and it seems to be growing by the year or so. The floppy eyelid syndrome, which we'll talk about, glaucoma, especially of the normal tension or pressure independent variety, keratoconus, some retinal vascular conditions such as hypertensive retinopathy, diabetic retinopathy, retinal vein occlusions. The last two, diabetic and retinal vein occlusion, there's a very high association between proliferative retinopathy and sleep apnea syndrome, especially if the sleep apnea is not well treated. Central serous chorioretinopathy, a relatively new association that has been identified in the literature. Optic disc edema, and this can be related to idiopathic intracranial hypertension, with obesity being a factor, but also non-IIH disc edema. Another type of disc edema that may be associated with sleep apnea is the non-arteritic form of anterior ischemic optic neuropathy. So we'll talk about all of these conditions. So who develops sleep apnea? Well, it can occur at any age, but it appears to be more prevalent in middle age. Risk factors include excess weight and obesity, and therefore it is probably underdiagnosed in adolescents and young adults. Again, that's the fastest growing group as far as the obesity epidemic is concerned. Pediatricians and primary care physicians are seeing a new type of type 2 diabetes patient, and that is the overweight adolescent. And so the sleep apnea syndrome probably underdiagnosed, but excess weight and obesity, male sex, although certainly females can get sleep apnea, physical inactivity is indeed a risk factor, an independent one for sleep apnea. Upper airway abnormalities, as we said earlier, enlarged tonsils, or just an anatomically small upper airway, alcohol use and abuse, loud snoring, although not all snorers have sleep apnea, it is an important risk factor. Family history, those with a first-degree relative, a parent, a brother, a sister with the condition have a much higher risk of developing sleep apnea themselves. There appears to be a loose association with general allergies, and that might tie into the whole keratoconus relationship. And then, of course, the wide neck circumference. So, this physical inactivity, again, this is not what we want, right? Physical inactivity, a risk factor for sleep apnea. And this is, a sort of kind of a typical finding. Or this is an obese young woman with the short, thick, kind of bull-like neck. And that is the prototype patient for sleep apnea, probably more if it were a man, but this is the prototype patient for sleep apnea. But you don't have to have this level of obesity and neck thickness to develop the disease. So when we talk about ocular complications, we can categorize them as far as changes in eyelid tissue. The floppy eyelid syndrome, patients have lax eyelids that can evert on their own, even if they're sleeping. The eyelid rubs up against the pillow and spontaneously everts, and the patient has these sort of dry eye, allergic conjunctivitis type symptoms. And then we've got changes in the cornea, including keratoconus, changes in the optic nerve, as we mentioned, the glaucomas, especially IOP independent or normal tension glaucoma, non-arteritic AION, and optic disc edema due to IIH or non-IIH. And then we've got changes in the retina. So this is one of our patients from Fort Lauderdale, Joe. Probably a patient that you were seeing in the glaucoma clinic. I probably was seeing the patient because they had diabetic retinopathy, but look at the long, luscious lashes. The patient is on a prostaglandin analog, and the lid is kind of low-lying and kind of lax, and it's easily everted.
Yes, I remember him well. I think his name is George, but I remember him being taller.
Is that right? Being taller. Okay, very good. But look at these kind of giant papillae as well. And here's another patient. This is a 40-year-old Black female with the floppy eyelid syndrome. It was very easy to evert these eyelids. And she also had an excess accumulation of orbital fat, but was recently diagnosed with sleep apnea and also had idiopathic intracranial hypertension to boot. So, this young lady kind of hit the jackpot here. But the history frequently includes obesity and type 2 diabetes. So when we see the patient who is obese and has type 2 diabetes, we really need to suspect obstructive sleep apnea, but also suspect the floppy eyelid syndrome. Treatment and management includes CPAP therapy, but we have to be careful about the fit of the CPAP machine so that it doesn't dislodge and cause even more dryness. Lubrication throughout the day and before bedtime of the eyes, sometimes a non-steroidal anti-inflammatory drop or a steroid. Really, it's whatever works, because sometimes these patients can have flare-ups and they can have remissions. And at times, there's enough corneal damage to require an antimicrobial drug, a broad spectrum antibiotic, and even a bandage contact lens or amniotic membrane therapy. But for the most part, many of these patients with the floppy eyelid syndrome in sleep apnea need more than one of these therapies. Combination therapy seems to work fairly well.
Somebody asked a question that came through. How is it OSA causes floppy eyelid syndrome? Is it correlated or is it causative?
That's a good question. It's an association. It doesn't mean causation, right? There is a theory. There's a theory that the elastin in the tarsal plate is abnormal, as well as the elastin in the throat being abnormal, and there might be a connection there. And so that's a good question. Causation and association are two different things. This is probably more of an association at this point, although there's some research to suggest that the tissue in the lid and the throat may have similar abnormalities. And yeah, in a bit, I'd like to hear some other suggestions on how to deal with the floppy eyelid syndrome in recalcitrant patients, because they can be really difficult. So vital dye staining, we may find an abnormally lax upper eyelid that spontaneously everts. The goal of treatment is to protect that ocular surface during sleep. We try to educate the patient to refrain from sleeping face down. It's pretty hard to sleep face down when you are wearing a CPAP. You pretty much have to sleep on your back or on your side. If worse comes to worse, there is an eyelid tightening procedure offered by oculoplastic specialists that we save for the last resort when it comes to the floppy lid disease. So what's the connection? As we said earlier, abnormal tarsal elastin and abnormal elastin of the throat, abnormal palatine elastin. The floppy lid patient has a patient profile that's fairly similar to the obstructive sleep apnea patient. These are people in their 40s and their 50s, occurring more frequently in men than in women. The patient tends to be a loud snorer with a wide neck. And here we can see tarsal elastin fibrils. These are these dark, kind of brownish black fibers. That is thought to be where the abnormality is. And so before we go to some questions and also a poll question, I just want to review this slide where sleep apnea can be a very serious condition if not treated properly and identified properly. From brain fog to depression to anxiety, hypertension, stroke, obesity, impotence, congestive heart failure, type 2 diabetes, low blood oxygen, and arrhythmias. So some of these complications can in fact be fatal. But do we have any questions in the chat?
No, Joe, I think you're all caught up.
Well, in that case, why don't we go to the first poll question if that's convenient? Here we go. A frequently encountered complication of obesity is, what is the title of this lecture? So it's not convergence insufficiency, it's not a corneal ulcer, and it is not toxoplasmosis. The answer is sleep apnea. Now, do we wait to look at the results of this poll, Joe, or do we just move on?
I'll wait for just a little bit. Joe,
Yeah.
how would one distinguish between floppy eyelid syndrome and dermatochalasis?
Usually by everting the lid, and you would see moderate to large papillae, as well as quite a bit of mucoid discharge. Also, sometimes just asking the patient, hey, do you feel like your lid, is flipped spontaneously? Sometimes they'll know. And so those are a couple of ways to hopefully distinguish between the two. But it's true that, there are some commonalities between the two, especially in our other patient that, she had the orbital fat and, but she didn't have dermatochalasis. She had the orbital fat and she had the floppy lid disease.
Joe, the other way to answer that too is, examination, grabbing the patient's lids. I have a few, I don't have that many floppy eyelids, but I mean, these lids, I have some video of it. It's almost, the elastin, you can almost, it's like a magic trick you can pull out on their eyelids.
That's right.
Where if it was, dermatochalasis,
Mm-hmm.
it would, you'd pull on the lid would be tight, and it would just, it might be like a brow ptosis where that, it goes away, but then
Yeah.
that eyelid is still tight. So
Yeah, I think so. I think that would be a good way to, distinguish as well.
And by the way, Joe, in almost 300 webinars, this is the first time anybody ever we pull a poll with 100% correct.
Well, yeah, a credit to the audience, right? Credit to the audience. So again, back to our patient here, our patient with type 2 diabetes, obesity, and obstructive sleep apnea. There appears to be a relationship, a bidirectional relationship between sleep apnea and type 2 diabetes. The American Diabetes Association goes so far as to recommend that all type 2 patients be screened for obstructive sleep apnea, and vice versa, that all patients with OSA also be screened for diabetes. So I want to spend some time on the retinal vascular manifestations of obstructive sleep apnea. This is really where my interest as a clinician lies, although we can't ignore the ocular surface as we just mentioned. But obstructive sleep apnea, this is associated with the development of diabetic retinopathy, the development of retinal vein occlusion, and the development of central serous chorioretinopathy. And in patients with existing DR, RVO, and CSC, it is associated with worsening or progression of the condition, faster progression. So the severity of obstructive sleep apnea, and then we can look at biological markers such as the apnea-hypopnea index, which I'll define. Both the severity of the disease and some of the biomarkers correlate with the severity of the retinal disease. And finally, dysregulation of certain genes known as the circadian locomotor output cycles kaput genes or clock genes that govern circadian rhythm is associated with the development of proliferative retinal vascular disease. So whether a patient has a vein occlusion or diabetic retinopathy, they are developing neovascularization of the disc and elsewhere to a greater degree, thanks to dysregulation of this clock gene. So early diagnosis is essential. Early diagnosis of the sleep apnea that's causing or related to the retinal disease. So OSA and retinal vascular disease both have a high cost burden on the healthcare system many times. And it's not just lack of working. Many times sons and daughters are taking off of work to bring their patient to the eye doctor. It's a very high cost burden when it comes to this condition. Obstructive sleep apnea creates systemic changes and hypoxic conditions, and this can either incite or worsen retinal vascular disease. And these changes can be the first clinical manifestation of otherwise undiagnosed obstructive sleep apnea. So look to the retina. Every time we look at the retina, we're looking at a tissue that represents the nervous system and the vascular system. So looking at the fundus can be especially revealing. And it's important if we identify clinical signs that may be associated with sleep apnea, and if the patient fits the profile, to refer that patient with new onset retinal vascular disease for appropriate sleep testing. And so, normally, the air flows freely past the structures of the throat. But in sleep apnea, we have collapse of the upper airway to the point where the airflow is completely blocked. There is a relationship between obstructive sleep apnea and weight. And I could attest to the fact that, if I get in shape and let's say lose 10 pounds, My sleep apnea absolutely improves. I feel, I don't stop the CPAP, but I feel even more well rested. Obstructive sleep apnea is a sleep disorder that affects an estimated 22% of men, approximately 17% of women, again, depending on what literature you read, but these are global estimates here. Approximately 75% of people with a body mass index greater than 40 kilograms per meter square. So that would be the, extreme obesity category. 75% of these folks have OSA, and 58% of moderate to severe OSA cases are attributable to a BMI that's greater than or equal to 25 kilograms per meter square. And that would be, 25 would be the overweight category, or category 1, grade 1 obesity. The prevalence of OSA has increased by as much as 55% in certain age groups in the last 2 decades alone. Now, is it really increasing, or are we just getting better at finding it? Is the healthcare community more aware? Let's look and see what happens to blood flow and blood gases during the night in patients with sleep apnea. So while the patient is awake, once again, the air flows in and out. Normally, the patient's breathing is normal. They fall asleep. The upper airway collapses, and there is no airflow when that airway becomes blocked. So blood levels of carbon dioxide rise, blood levels of oxygen fall, blood pressure increases to keep the patient alive. And after a while, there's a period where the patient will gasp or gag, right? And so this brief arousal then opens up the airway temporarily, restoring the blood gases to normal levels, but then the cycle continues to repeat itself. So you've got apnea, recovery, apnea, recovery. And as you can imagine, a whole night of this is not very good for the retina, and it's not very good for the optic nerve. So does your patient have obstructive sleep apnea? So we can ask them about snoring. So oftentimes it's, the patient's partner. My wife is the one that diagnosed my sleep apnea. So snoring marked with frequent changes in loudness and frequency, as opposed to steady, quiet snoring. So when the snoring changes in loudness and in frequency throughout the night, this is highly suggestive. If the patient reports excessive daytime sleepiness, tiredness, fatigue, especially when they're not particularly active. If the patient's partner reports episodes during sleep when their partner's breathing stops. If there are periods of loud snoring that are then followed by silence, or a total absence of breathing lasting from a few seconds up to even a minute or longer, this is also highly suggestive. So risk factors, I think we covered these: obesity, excess weight, male sex, upper airway abnormalities, alcohol use, loud snoring, and a neck girth of more than 17 inches in men or 16 inches in women. And then when the neck girth exceeds 19 inches for both men and women, virtually everybody, something like 95% of those folks have obstructive sleep apnea once the neck girth reaches 19 inches. But even a 16-inch, 17-inch neck may be related to sleep apnea. So feeling fatigued in the morning, especially. In my case, I was sleeping 8, 9, even 10 hours. I'd wake up the next morning and just feel tired. I've never fallen asleep during the day, which is probably a good thing. Memory loss, an issue, poor judgment, and irritability, personality changes. I noticed that I was, kind of mean to my students, a little bit short with them. It didn't really affect my judgment, I don't think, as a clinician, but it definitely affected my personality. So why are there ocular vascular complications in sleep apnea? What are some of the connections? What is the latest research telling us? And you'll see little numbers in parentheses. These are from an article that I'll put up at the end. These are references from that article that you could then look up. So the primary drivers of ocular complications are the intermittent hypoxia, sympathetic nervous system activation, which when you think of central serous chorioretinopathy, that makes sense, right? Primarily, blood flow through the choroid is controlled by the sympathetic nervous system. So if we have overactivation of the sympathetic nervous system, it can cause a sort of hyperperfusion to the choroid, resulting in a central serous chorioretinopathy. So hypoxia, sympathetic activation, oxidative stress, which seems to be implicated in so many ocular vascular conditions, from diabetic retinopathy to AMD to some non-vascular conditions like glaucoma, although I guess there's a vascular theory for glaucoma that's pretty strong as well. And then adverse effects from something known as endothelin-1. And this is a potent vasoconstrictor that is produced by vascular endothelial cells. So retinal vascular disease also has a high economic burden on healthcare systems. Diabetic retinopathy alone cost the United States healthcare system $4.5 billion in the year 2020. Here's another representative patient. This one's a little taller, 5'10", reported weight of 295, but this guy was probably 325 to 340, complaining of central blur, type 2 diabetes, and the trifecta, diabetes, hypertension, and dyslipidemia, that is now becoming more of a quartet in obstructive sleep apnea. My wife is an optometrist in a VA hospital, and she is telling me that many of her patients with type 2 diabetes, hypertension, and dyslipidemia also have obstructive sleep apnea, and the majority are obese as well. And I'm finding that certainly in San Antonio, Texas, I'm finding that as well. So Orlando and San Antonio. So here's our patient, the right eye, best corrected acuity, 2100. And, we could see why. We could see that this macula, the fovea, is elevated. You could even see the xanthophyll pigment, that yellowish hue, the zeaxanthin and the lutein that's in the macula. You can actually see it because the macula is so raised, along with many blot hemorrhages. So it's not just dot hemorrhages and microaneurysms. It's reached the stage of a blot hemorrhage, which indicates more extensive damage to the capillary wall. And the left eye, fairly similar findings, with the arteriolar sclerosis, hypertensive retinopathy, cotton wool spots, the dots, the blots, the MAs, and the macular edema. This eye is 2200 in our patient with sleep apnea. And you could see here on the OCT where the foveal thickness is roughly twice the thickness of a normal fovea. And what we frequently see are these large interretinal cystic pockets of fluid, and especially in sleep apnea. So, which factors most influence the onset, the progression, and the visual outcome of diabetic retinopathy. So I've looked at the literature in this area, and guess what? It's not just the sugar, right? We have to go beyond the hemoglobin A1C, although that is a big determinant, no doubt. But there are many, many factors, systemic and ocular, that can exacerbate diabetic retinopathy or lead to the development of retinopathy in an eye that previously does not have it. And so, you know, you could read the list as well as I can. I just want to highlight a few of them. Hypertension, systemic hypertension, is an independent risk factor for diabetic retinopathy. That means that if your patient has hypertension, they're at a significant risk for developing diabetic retinopathy in their lifetime, whether they have diabetes or not, because that is an independent risk factor. And then we've got some serious chronic conditions, the dyslipidemia, the carotid occlusive disease, kidney disease, which is one of the three microvasculopathies in diabetes, the other two being retinopathy and neuropathy, right? So nephropathy, neuropathy, and retinopathy, the three microvasculopathies, small blood vessel complications of diabetes. Sleep apnea, more and more, is being cited in the literature as one of those systemic conditions that can drive the retinopathy, along with anemia, obesity, vasculitis. So I've taken to having my patients smile because I want to be able to see their gums. And if their gums are bleeding or they're missing teeth, that means they've got vasculitis. Okay, neuropathy, peripheral neuropathy and diabetes. We talked about kidney disease and vitamin D deficiency. A patient, especially in patients of darker complexions living in North America. Okay, many of them are deficient in vitamin D, and for pennies per day, you know, they can get their vitamin D levels up, as well as some sensible sunlight. So, obstructive sleep apnea and diabetes, this relationship is in fact bidirectional. Just as OSA may increase the risk of developing diabetes, diabetes is a risk factor for developing OSA. And during REM sleep, an increased apnea-hypopnea index, that's the second time I've referred to this. This is the number of apneic and hypoxic or hypopneic events per sleep hour. So this AHI during REM is linked with diabetic retinopathy, even when controlling for other risk factors such as hypertension. And I want to kind of veer off and talk about how technology is starting to help us in optometry to really better classify and manage diabetic retinopathy, and especially diabetic macular edema. Optical coherence tomography and also OCT angiography have forever changed the classification and management of diabetic retinopathy. So in order to get this type of data, one must run a volumetric, also known as a cube scan, where many horizontal and vertical slices are taken within a particular area. In this case, the area centered around the fovea. So we've got our near infrared image on the left, and superimposed over that is our thickness map. And as you could see, according to the scale just to the right of the optic nerve, you know, this entire, really pretty much the entire macula is extremely thick. And then to the right of that, we have our 9-zone. It's called the ETDRS thickness grid, based on the old early treatment of diabetic retinopathy study, uses the same subfields. And you could see that the instrument takes the average retinal thickness of all of these 9 subfields, each of these 9 subfields centered around the foveal center. And then our regular fundus image on the right, you could tell that there's some microaneurysms, probably some thickening of the tissue. And then finally, the horizontal B scan on the left. And remember, this B scan represents one slice, right? There are many more horizontal and vertical B scans. So if we go just a few microns this way, or vertically, this may look totally different. But you could see here, yes, there's a posterior vitreous detachment that has now separated. And we've got those inner pockets of fluid, right? They're not real cysts because real cysts have cell walls, but we still call it cystic or cystoid macular edema. So now we call this center-involved diabetic macular edema. And remember that DME, diabetic macular edema, may occur during any stage of retinopathy, whether it's early, moderate, severe non-proliferative, whether it's proliferative, it doesn't matter. Diabetic macular edema can occur at any stage of retinopathy. But it is more common. It occurs more commonly and to a greater extent in people that also have the sleep apnea syndrome. And if we look at some of this cystic DME and anti-VEGF treatment, those large cystoid spaces in the inner retina, right, at baseline, this appears to correlate with a poorer response to the anti-VEGF medications. And so a drug such as Avastin, which is commonly used off-label, may just not be potent enough in patients with sleep apnea with this large cystic macular edema. We may need to go to a much more potent medication, whether it's faricimab or aflibercept or ranibizumab. And you can see also here, we've got a partially attached PVD, but it's also partially attached right here. And so this sort of micro trauma from the PVD that is causing some traction on the fovea, guess what that does? That also upregulates the vascular endothelial growth factor, so that exacerbates the diabetic macular edema. Now compare that to our image on the lower right, where the macular edema is more diffuse, more sponge-like. And we could see on our pictures, right, the color photo, the red-free, and also on the OCT-B scan, we can see the hyperreflective, these are probably hard exudates. But when there's diffuse DME, this appears to be associated with a better response to treatment with the anti-VEGF drugs. Let's check the chat box. So, is the retinal vascular damage in sleep apnea related more to hypoperfusion or acidosis? The literature is leaning a bit more toward hypoperfusion, and I have some more coming up on that just to tease you, but probably more the hypoperfusion. Although the acidosis does set up a state where there is oxidative stress, so I believe both are contributing factors. Any other questions or comments?
No, I think you caught up, Joe.
Shall we go to poll question number 2? Periods of cessation of breathing during sleep due to upper airway obstruction are called A, apneas, B, asthmas, C, aortas, D, aneurysms. Just making sure that folks are awake. Conscious. Seeing if they have a pulse, Joe. How'd we do on that one?
I think they got a pulse.
Right. I'm not here to trick anybody, guys. And yes, we still teach this in optometry school. Clinically significant diabetic macular edema, right? We still teach this in optometry school for a couple of reasons. Number one, not every OD out there has immediate access to an OCT. Many do, probably more than 50–60% of optometrists do have immediate access to OCT, but what about the other 40% who do not? This is still a very good clinical guideline for treatment or referral to a retina clinic. So retinal thickening within 500 microns of the foveal center on the lower left, right? Or hard exudates within 500 microns of the foveal center if associated with adjacent thickening of the retina, or retinal thickening of greater than 1 disc area in size, any portion of which is located within 1 disc diameter of the center of the fovea. Most of the colleagues that are on this webinar or synchronous activity, or whatever you like to call it, Joe, most of you know this by heart. Some of you have it tattooed on your upper arm. But this is a 1985 definition, a clinical definition that still applies, and it's good to go by this definition if you don't have an OCT. But that being said, it is older criteria, and nowadays the definition of diabetic macular edema and classification has been altered because of optical coherence tomography. So now, if there is diabetic macular edema, the question is, does it involve this central foveal subfield? And this came about during the randomized clinical trials of the anti-VEGF agents. They used the presence of DME in that central subfield as a criteria for treatment. So older ETDRS definition that we just reviewed, the older definition of clinically significant diabetic macular edema, has now been modified in the era of OCT. Finally, it's great to have progression analysis on our OCT, or software where you can track your patient over time. So here is a patient with diabetes and sleep apnea on their first visit, and this is over a year ago, and the patient has pretty much they've had to get monthly injections. I think they may have missed a few months during the COVID pandemic, and then came back with more edema. But this is the previous visit, right? So on our thickness map, we could still see some hot areas there, but at least on this cross section, we have fairly normal foveal depression. Sure, some intraretinal fluid, I should say. And here's the current visit. Again, still improving just a little bit with one fairly recognizable pocket there. So this gives us an idea of how well the treatment is or isn't working. I snuck in this slide. It may not be in your handout, but what is multimodal imaging? Multimodal imaging comes in really handy in just about all retinal vascular disease. And this term refers to the use of multiple technologies to take pictures. And this is something that we've been doing for a long time. Now it just has a name. So these instruments may include hybrid devices that do more than one thing, or several different instruments that all do different things. So multimodal imaging does not replace, but it rather augments the traditional dilated retinal examination. And here's an example of how we use multimodal imaging in diabetic retinopathy. And so we have OCT and OCT angiography. The OCT angiography, this is really one of the areas where it shines. And we've got microaneurysms that you can see right here and here and here. We've got sort of a distortion and enlargement of the foveal avascular zone, and a reduction in the density of those blood vessels. We could see some capillary dropout. And to the right, we've got an OCT angiographic map of the optic nerve, and guess what we have? Neovascularization of the disc. Here it is below on our structural OCT. When you see something like this, you really have to go back and look fundoscopically, because NVD can be really, really subtle. Lower left, now we've got our cube scan, right? Our volumetric scan, and this is our PDR, where on the retinal surface we have proliferation of brand new blood vessels, and here it is in another area as well. So you've got the microaneurysms, the foveal avascular zone changes, the neovascularization of the disc and elsewhere on OCT. And some OCT instruments actually have the ability to quantify some of this non-perfusion. So that could be really handy to have. What is the purpose of multimodal imaging? Well, to help us, right? Help us diagnose, help us prognose, help us manage, help us monitor a disease process. And in these patients with diabetes and sleep apnea, we need all the help that we can get. So some of these common modalities include color and multicolor fundus imaging, near infrared reflectance, which you get on every OCT you do. You'll get a near infrared image. Fundus autofluorescence, right? A non-invasive method that is dependent upon lipofuscin buildup within the RPE cell, and the use of either a filter, bluish or green filter, over a standard fundus camera, or some sort of confocal scanning laser device. And then we've got OCT and OCT angiography. And so another point that I would like to make here, especially in our sleep apnea patients, that diabetic retinopathy is not exclusive to the central retina. So a lot going on in this image on the lower left, certainly in the posterior pole, but we could get into the mid-periphery. We've got sort of an omega loop here. We've got pre-retinal heme here and here. So anytime we see pre-retinal heme on a patient with diabetes, we are fairly certain that it is proliferative disease. And even as you get out to the more peripheral aspects of the retina, there is plenty of ischemia and retinopathy. And by the way, this eye also has glaucoma. The left eye of a different patient, again, you could see, look at this network out here of neovascularization. So it is time that we move beyond, just the disc and the macula, and really pay attention to the mid and the far periphery in our patients with diabetes. And the OCT angiography is getting better and better, and you need to decide whether this sort of upgrade is for you. If you have a practice that is high in patients with diabetes, with AMD, with any sort of retinal vascular disease, I believe that you can easily justify the purchase of OCT angiography. If your practice is more the general practice, then I think for now a standard OCT instrument will be just fine. But look at these areas of non-perfusion, right? Oftentimes there are these squirrely vessels, these ERMA, within the areas of non-perfusion, and that is not by accident. And so here is OCT angiography in another eye with PDR. On the left, we have our superficial capillary plexus, which is located within the retinal ganglion cell layer. And as we look at the image below, this B scan with the blood flow overlay, you could see that it does include from the pre-retinal zone down through that superficial capillary plexus. So we could see all the non-perfusion, and then we also see this neovascularization elsewhere on the retina. We adjust our slab to include just the vitreoretinal interface, and clearly we can see that tuft of neovascularization. And finally, the point here is that OCT is becoming more and more and more wide field. And so we can see proliferative diabetic retinopathy when we have this sort of appearance with this hyperreflectivity in an eye with diabetes. This is most likely neovascularization. So go back, hopefully it's something where you saw it fundoscopically, and now you're just doing an OCT to document it and describe it further. As far as making the diagnosis of sleep apnea, the main testing is known as polysomnography. It used to be that you had to go to a hospital and do an overnight sleep study. And if there's time, I'll tell you the story of my polysomnography some 20 years ago. But now it's done primarily at home. I just did an at-home test, and based on the results of that at-home test, I'm getting a new CPAP later on this week. So it includes eye movement observations for REM sleep. It includes an electroencephalogram, chest wall monitoring, an electrocardiogram, an electromyogram to monitor limb movements, and oximetry to measure oxygen saturation. And this is the pulse oximetry. These, maybe some of you actually were using this during the COVID pandemic. I know some clinics were, but here it is. It goes right on the fingertip, and it uses red and infrared light. Small beams of light pass through the blood in the finger. This measures the changes of light absorption in oxygenated and deoxygenated blood, and it measures oxygen saturation levels along with the heart rate. So a couple of important parameters. We have the respiratory disturbance index, or RDI. This refers to the number of obstructive breathing events, or apneas, per hour. And this is the standard that is used to diagnose as well as grade the severity of the OSA. Then there is the apnea-hypopnea index, the AHI. Apneas are strongly associated with reduced blood oxygen, and they can decrease the blood oxygen by up to 4%. Then we have these respiratory effort-related arousals, also known as RERAs. And this is another breathing disorder, usually happens during sleep, characterized by obstructive upper airway flow reduction. So airflow reduction, but it does not meet the criteria of an apnea or a hypopnea. So it is a respiratory effort-related arousal. It is some sort of breathing disorder, but it does not meet the criteria for an apnea. What is a hypopnea? This term refers to events in which there is a decrease, but not a total cessation of breathing during sleep. So to calculate the apnea-hypopnea index, you simply add the total number of events. You add the apneas, the RERAs, and the hypopneas, divide that by the total number of hours slept during the study, and you have your apnea-hypopnea index, and we want that to be relatively low. The lower, the better. Back to these clock genes, these have a role in coordinating circadian rhythm, metabolism, and homeostasis throughout the body. And dysregulation of the expression of the clock genes has been documented in OSA, as well as altered expression of other specific genes, such as the cryptochrome circadian regulator 1 gene and the period circadian regulator 3 gene. These may even be independent predictors of the severity of sleep apnea. And dysregulation of these clock genes is also thought to be directly related to the pathogenesis of retinopathy in patients with sleep apnea and type 2 diabetes. Upregulation of another clock gene known as DEC2, this increases VEGF, the vascular endothelial growth factor, leading to increased rates of neovascularization and to macular edema, especially under the hypoxic conditions that occur in patients with sleep apnea. So some fairly elegant research has been done on the relationship between sleep apnea, diabetic retinopathy, and diabetic macular edema. This is just one study, but I could quote more with respect to diabetic macular edema. It has a higher prevalence, a higher recurrent rate, and it is less responsive to anti-VEGF therapy in those diabetic patients who have sleep apnea. Likewise, proliferative disease is more prevalent and occurs to a worse degree in patients with both conditions. Also, improvement of the macular edema and even the proliferative retinopathy has been shown with CPAP use. Probably you can't really reperfuse the retina, but it does improve the appearance at times. One thing that we know now that we didn't know, 30 years ago when I was a student, is that leukocytes, white blood cells, once inside retinal tissue, they then go ahead and secrete a variety of inflammatory substances, such as tumor necrosis factor and VEGF. And then these inflammatory mediators then increase the vascular permeability, leading to edema. And this stimulates and enhances that inflammatory reaction. So the burden of care for diabetic macular edema is high, especially in those diabetic patients with uncontrolled sleep apnea, resulting in subpar efficacy of treatment. And so obstructive sleep apnea increases the likelihood that a patient will be a poor responder to anti-VEGF. Doesn't mean they won't respond, but they may need to continue to receive monthly treatment for years and years and years. Other patients, you might be able to extend the treatments, so that it doesn't have to be every month. But this can lead to persistent vision-altering diabetic macular edema, this poor response to anti-VEGF. It can lead to increased frequency of injections and potential escalation of care to more expensive alternative treatments, whether it's an intravitreal steroid or panretinal photocoagulation. Other ocular associations that I'd like to cover include central serous chorioretinopathy. Here we could see our sensory retinal detachment that is localized, and about the only perfect smokestack that I've seen in 30 years of practice. Usually you get the hot spot and it will fan out a little bit, but this one was perfect, so I put it in. Likewise, central retinal vein occlusions appear to be associated with sleep apnea. First, the vein occlusions. So for decades, hypertension was thought to be the prime mediator of retinal vein occlusion in patients with sleep apnea, but more recently, it appears that there may be a more direct link between sleep apnea and the pathogenesis of retinal vein occlusion. So it's the nocturnal hypoxia, and this potentiates the vaso-occlusive event because of increased sympathetic activation, along with peripheral vasoconstriction, that endothelin-1 byproduct that I mentioned earlier, oxidative stress, and direct endothelial damage that is both acute and chronic. And this combination results in stasis of blood flow, which after all is the most common cause of CRVO. We have stasis and damage to the blood vessel endothelium, and this increases the likelihood of overnight retinal vein occlusion during hypoxic events. And so we see the clinical picture. I just had one of these the last time I was in San Antonio. This commonly results in the clinical picture of a patient with obstructive sleep apnea waking up from sleep with a new, painless, unilateral vision loss due to central retinal vein occlusion. A little bit more on obstructive sleep apnea and central serous chorioretinopathy. So some studies have found that although sleep disorders, essential hypertension, and other factors may contribute to the risk of CSC, the main risk factors for central serous are male sex, age range from 45 to 54, and recent steroid exposure. These are the three strongest risk factors for central serous chorioretinopathy. And I believe that pregnancy may be in there as the number 4. However, when obstructive sleep apnea is considered as a risk factor independent from other types of sleep disorders, it does confer a significant increase in the risk for developing CSC. So the pathogenesis is attributed to both sympathetic activation and an attenuated parasympathetic reactivity, which impairs autoregulation of choroidal circulation. Yes, the majority of circulation through the choroid is controlled by the sympathetic nervous system, but there is a small component that is also on autoregulation, where the vessels will constrict and dilate as needed. So when that system gets impaired, it can result in leakage that affects the outer blood-retinal barrier. So OSA can cause significantly elevated circulating levels of two things, epinephrine and cortisol. So an increase in endogenous glucocorticoids and epinephrine, and this leads to the autonomic dysregulation and an increased risk for CSC. Shall we visit the chat room?
You're good?
Yes, let's do a poll. Although type 2 diabetes patients, all type 2 diabetes patients who are obese should be screened for A, ulcerative colitis, B, restless leg syndrome, C, pseudotumor cerebri, D, obstructive sleep apnea. Again, just making sure that you all have a pulse.
Mm-hmm.
Although, one thing I have not looked up, and I wonder if you guys know or if anyone knows, whether there's a relationship between obstructive sleep apnea and the restless leg syndrome. My wife claims that I have restless legs, and I believe her. I don't know if that's just a coincidence that I've got both, or if there is some sort of relationship. Who knows?
I'm not aware, Joe.
Nor am I, but I've not looked it up either. Again, 100%. Wow, we can make this a perfect, course here. All right, let's talk about the glaucomas. And, I think there's a little something to this theory, and there's a lot of debate in the glaucoma community. But, this particular study was well done on continuous intraocular pressure monitoring during sleep at night in patients that had obstructive sleep apnea. And the theory is that those subjects tended to stop inhaling, but not exhaling, during their airway closure, and that should lead to a lower intrathoracic pressure. However, those same subjects also experienced hypoxia, such as cessations in breathing, and that caused their oxygen saturation levels to drop in their blood, possibly triggering direct damage to the optic nerve. So the nerve theoretically could be damaged due to hypoxia, even without a spike in IOP. And this might explain why there seems to be a lot of literature around sleep apnea occurring in patients with normal tension or pressure independent glaucoma. You don't necessarily need to have IOP to develop glaucoma. You don't necessarily need to have high IOP to develop sleep apnea either. So in another study, Sang found a 4 times higher incidence of glaucomatous disc changes and increased subnormal visual field indices in the sleep apnea group compared with controls. And again, these N numbers, the subject numbers, they're not particularly high, but when you do a meta-analysis, there seem to be some trends. What's the connection? Again, we've got theories that link glaucoma to sleep apnea. One of them is impaired blood flow to the optic nerve, secondary to these repetitive long apneas and hypopneas, right? Then there's the optic nerve vascular dysregulation theory, where secondary to arteriolar sclerosis and episodic nocturnal hypertension and hypotension, we can have damage, glaucomatous damage taking place. And then finally, hypoxic episodes causing direct damage to the nerve fiber layer axons. Corneal hysteresis, so this term refers to the cornea's relative ability to absorb pressure by bending. And it's been shown that low corneal hysteresis is associated with glaucoma. So here's a study that was done in 2017 and showing that corneal hysteresis is reduced in obstructive sleep apnea patients, theoretically putting them at higher risk for developing glaucoma, whether their IOP is high or not. While we're on the topic of the optic nerve, let's talk a bit about the non-arteritic form of anterior ischemic optic neuropathy. This is the less serious form of AION, the more serious form being secondary to giant cell arteritis. The preeminent cause of non-arteritic AION is ischemic vascular disease, and I am lumping sleep apnea into that group of ischemic vascular diseases, just like diabetes, just like hypertension, and just like arteriolar sclerosis. And we could see here at first, the disc is hyperemic and it's swollen, right? So it's kind of pink looking and it's swollen. And we've got our altitudinal field defect here, right? And we've got some thickening of the retinal nerve fiber layer, particularly inferiorly and inferior temporally, thanks to that disc edema. But then in B, this is several months later, we can see that the disc becomes pale and atrophic. And the visual field defect is still there. Now it could improve, it could recover to some degree, but the patient will be left with some degree of optic atrophy, some degree of field loss, although recovery can be near complete in some patients. First thing we have to do is to rule out the arteritic form due to giant cell arteritis. And treatment and management really is systemic for this non-arteritic AION. Control of blood pressure, control of sleep apnea, control of diabetes, that list of factors that can exacerbate the retinopathy that I had up there earlier, that all needs attention. Get a vitamin D study, get a hematocrit on your patient, and so forth. So sleep apnea syndrome, diabetes, and hypertension are related to non-arteritic AION, where we have disc swelling that is hyperemic. Believe it or not, this has a fairly good prognosis. Many of these patients will recover to 2040, 2030, 2025. Again, the Snellen chart, really isn't a great measure of visual function. We have to go to a visual field and see how much of the remaining field defect there still is after the disc becomes atrophic. Whereas this pale swollen disc on the right, this is going to be more characteristic of the arteritic form of AION, which is due to giant cell arteritis. So look for the pale disc swelling. As a rule, patients will be roughly 10 years older if they have arteritic AION compared to non-arteritic, as a rule. The visual acuity will tend to be 2200 or worse in the arteritic form. It should be better than 2200 in the non-arteritic form. So what's going on in the non-arteritic form? We've got an alteration of the blood supply to the optic nerve head. Simple as that. It's an ischemic process. It affects the short posterior ciliary arteries. And as this ischemic episode evolves, the disc edema itself compromises circulation, and this leads to further damage. So common etiologies of non-arteritic AION include cardiovascular disease, diabetes, arteriolar sclerosis, and obstructive sleep apnea. Again, an example on top of non-arteritic AION, hyperemic swelling. Control the systemic factors there. Get the patient on a CPAP if they're not on a CPAP. And the pale swelling that is a true ocular and medical emergency in the arteritic form of AION. We must rule this out. And eventually, the patient with the non-arteritic AION will develop some degree of optic disc atrophy or optic disc pallor, usually in a sector such as this. And so we could expect the nerve to look like this several months after the episode. Visual field testing, it's not always an altitudinal defect, but it has a predilection for either the superior or inferior hemisphere in non-arteritic AION. And that was the case in this patient. Superior pallor, inferior defect. So, keratoconus.
Before you change topics,
Yeah.
there was a question: is there any association with simple mild nerve pallor and obstructive sleep apnea versus just a major event like non-arteritic anterior ischemic optic neuropathy or glaucoma development?
Oh, that's a good question. I mean, optic neuropathy, there's a wide range of severity. So even a non-arteritic AION could be fairly subtle. And so that may result in a bit more generalized pallor. I've seen it in sleep apnea. Sometimes there are other factors going on. I think we need to do our diligence in ruling out things that are, more life-threatening. I don't know if I have the time, but I do have a case of a patient who we ruled out everything, and it was just sleep apnea. It was just so he had swollen discs, both of them. Didn't seem to have IIH, did not have IIH, but ended up being diagnosed with sleep apnea and improving. And so, sometimes you will end up with some optic atrophy. Although if the atrophy is more generalized, I would again want to rule out other conditions such as an optic neuritis, demyelinating disease, that sort of thing, before going with sleep apnea as the cause.
Yeah, Joe, I agree with you. Obstructive sleep apnea to a lesser extent, and non-arteritic anterior ischemic optic neuropathy to a greater extent tend to be diagnoses of convenience, where somebody will see something as we describe here and twig off on one of those two as the explanation without doing the full workup.
You're right on, Joe. Now it can be the explanation, and but you do need to hopefully go through the process with the proper ophthalmic testing, and if necessary, serology and other even neuroimaging in some cases, again, depending on the severity of the disease. So, any other questions?
No, I think you got it, Joe.
All right, let's go to keratoconus. And I'm by no means an expert in this area, but it involves traditional and special diagnostic testing. The floppy eyelid syndrome has been linked with both obstructive sleep apnea and keratoconus in several studies. Obesity has been linked with keratoconus. Treatment and management of keratoconus, I'll leave that to our wonderful contact lens specialists that do such a great job with the RGPs, with the sclerals, with reverse geometry lenses, but just be aware of the association. Marfan syndrome related complications involve facial anomalies. They may also present with ectopia lentis, or a decentered crystalline lens, and this is due to disruption of the surrounding zonular fibers. Patients with ectopia lentis are at a high risk for retinal detachment. Half of all patients living with essential hypertension also have sleep apnea, and half of patients with sleep apnea also have essential hypertension. So there's an intimate relationship here. Therefore, obstructive sleep apnea appears to be a contributing factor in the development of essential hypertension, which is roughly 95% of all hypertension cases are essential hypertension, where there may not be a definitive cause, although sleep apnea may be an issue, so it should be ruled out. Other systemic diseases, congestive heart failure, pulmonary hypertension, stroke. Here's a big one. Obstructive sleep apnea is an independent risk factor for stroke. If your patient has sleep apnea, they're at a higher risk for developing a stroke, whether they have hypertension or not, because it is an independent risk factor. The metabolic syndrome and type 2 diabetes. So we know the metabolic syndrome is characterized by abdominal obesity, right? And the abdominal obesity or central obesity, that's going to be more damaging because it involves visceral fat that surrounds the organs, as opposed to subcutaneous fat. Throw in dyslipidemia, high cholesterol, high triglycerides, raised blood pressure and insulin resistance, and you've got the metabolic syndrome. Why should we care? Because of end organ damage. And those end organs include the eye, the retina, the heart, amputations, right? The extremities, and the brain. The term diabesity has been coined for a couple of decades now in the public health literature, because virtually all new type 2 diabetes cases are caused by excess weight. Obesity is in fact a disease of increased weight caused by the excess accumulation of fat. And yes, the body mass index is more or less the standard measurement, but it's not It's not always accurate. There's a term out there called overfat, where a patient may have a quote unquote normal BMI, but a large waist, indicating more visceral fat. And so once again, these four factors interacting to form the metabolic syndrome, we spend 75 cents out of every healthcare dollar fighting complications of the metabolic syndrome. And, there's our sleep apnea when it comes to the pathology of obesity. But as you could see, it is in fact a multi-system disease, from type 2 diabetes to heart disease, even things like GERD and cancer, high blood pressure, sleep apnea, affecting virtually every body system. Any three of these or more are diagnostic of the metabolic syndrome. Note that they use waist circumference instead of body mass index. Okay. And so we've got the insulin resistance resulting from the metabolic syndrome, leading to early cardiovascular disease, microvascular disease, including blindness from retinopathy, right? Kidney failure, and we really ought to have neuropathy there as well as a microvasculopathy. The microvascular disease can also cause macrovascular diseases, leading to amputations, leading to stroke and coronary artery disease. And you've seen these maps before, but as recent as 1994, not a single state in our union had an obesity rate higher than 20% for adults. Fast forward to 2012, and not a single state has an obesity rate below 20%. And, no matter what maps you look at, here's obesity on top, right, from 94 to 2007, and diabetes. The two absolutely kind of mimic one another, right? The obesity rate and the diabetes rate. Here's obesity trends in 2014, where now, for the first time, we have 3 states where greater than 35% of the adult population is obese. And here's the same for 2019. So this belt of states, this is the diabetes map, okay? So you just saw the obesity map. This is the prevalence of diagnosed diabetes map, which, the national prevalence of diabetes.
Let me just hang the coat. It's okay, Saki.
What is that? So the prevalence of diabetes in the US is now greater than 10%. But look at this belt of states. It's known as the diabesity belt. And, you guys do a lot of traveling, as do I. And, in some states, it's hard to find vegetables that aren't deep fried, Again, 2013, prevalence of diagnosed diabetes by county. I think you guys get the idea. What questions do we have? Let's see the chat box. So, let's do our question first, huh? Effective interventions for sleep apnea include CPAP therapy, continuous positive airway pressure, diet, exercise, and weight loss. Choice number 2, bloodletting and frequent enemas. My goodness. Deep heat massages and spinal manipulation for our osteopathic friends in the audience, and increased alcohol uptake. Beer. It's not just for breakfast anymore.
I often like to prescribe a good leaching too, Joe.
Nothing like a good bloodletting. Oh boy. Where are
John,
we?
there's a question in the chat if you want to take it now.
I see it. So you have a patient who you think has sleep apnea. How do you move forward? Yeah, let's do this. Let's move forward. Here's what we do. Let me fast forward, because that's what Look at the David after spending 3 years in the United States. My God, Michelangelo, Michelangelo rolling over in his grave. So perfect segue here. Now what? Well, we should refer those patients with the ocular findings that we're talking about for a sleep study, particularly if the patient fits the obstructive sleep apnea demographic profile or complains of sleep disturbances. Absolutely. And sleep clinics, typically they are pulmonologists, but I've seen neurologists as sleep medicine specialists. So, find out who in your area is doing sleep medicine and doing it effectively, and set up a referral network both ways, because hey, you're the person that sees all the patients with glaucoma. You're the person that sees the patients with keratoconus, floppy lid disease, retinal vascular disease. Similarly, sleep medicine specialists should recommend that all their patients have a thorough ocular health exam. So more cross referrals support better outcomes for our patients. Years ago, Joe, we had a case, and the resident actually published it. I was the second author. Really well done case, and it led to a literature review. And she and I presented at the American Academy of Sleep Medicine, which was conveniently in Fort Lauderdale at the time, but that was over 10 years ago. So proper treatment of sleep apnea with CPAP therapy has been shown to improve visual sensitivity, improve retinal nerve fiber thickness. It's essential to recognize the link between these disorders and OSA, not only for the preservation of visual function, but also for proper treatment and mitigation of morbidity and mortality due to undiagnosed and untreated sleep apnea. You want to do one more poll question or skip to the end? Let's do it. Obstructive sleep apnea is A, due to excessive weight loss while dieting. B, more common in obese patients. C, less common in obese patients. D, rare in type 2 diabetes. Again, another pulse check. Here's what I've done. I think this is in your handout. I've put together, this is from the article that Dr. Helen Abdal and I published, like 12 years ago. But we came up with this sleep history for ODs. So this is something that you can ask your patients in 5 minutes, right? A brief sleep history in the eye clinic for patients that maybe fit the profile. So feel free to use, it's not rocket science, right? Do you have frequent headaches, especially in the morning after awakening? That's a big one, by the way. Closing thoughts. Sleep apnea causes hypoxia, sympathetic overaction, hormonal dysregulation that can lead to a number of ocular and ocular vascular conditions, many of which can lead to permanent vision loss. Treatment of the ocular conditions without addressing the underlying sleep apnea, that's ineffective or suboptimal management. And it's a significant cost burden to the patient and the healthcare system. So investigation and appropriate treatment of sleep apnea is essential to improving visual outcomes and, more importantly, enhancing our patients' quality of life. This is one of the articles, the main article that I used for many of the references, and you could look this up if you want. I probably have a reprint of it if you're looking for that. But hey, I want to thank you guys for having me on this, this interactive activity, and it's been a real pleasure sharing this information about sleep apnea with everyone. Thanks for your participation. Joe and Greg, thanks for helping me out on the Q&A and adding your opinions, which I value. And hopefully we'll see you all down the road very, very soon.
Well, Joe, looks like the questions are caught up here. You're getting your virtual thank you. See, okay, so thank yous coming in. So I'll say
Okay.
thank you for doing this, the eye in sleep apnea, a synchronous virtual course. That will end the CE. We appreciate you.